right, welcome everyone to the Systems Thinking in Longevity Medicine A4M educational webinar. Before we get started today, I would like to share that any questions will be addressed at the end of the webinar. If you do have questions, please use the Q&A icon located in the Zoom toolbar. Today's webinar will be recorded and available on the A4M website for your convenience. Our speaker for today's webinar is Dr. Sahar Swidan. Dr. Sahar Swidan is President and CEO of Neuropharm and serves as Adjunct Associate Professor at George Washington University School of Medicine. She's board certified and an advanced fellow in anti-aging and regenerative medicine, with international recognition as a speaker in pain management, headache medicine, and hormone optimization. Dr. Swidan has authored numerous publications and most recently co-authored Mastering Chronic Pain, a guide for clinicians focused on root cause pain recovery. Before we get started, I'd like to share a special promotional code for our attendees today. Please use code WEBINAR100 for $100 off of registration to attend our Module 3 Frontiers in Brain First Longevity being held in Nashville, Tennessee from September 17th through the 19th. Now let me turn it over to Dr. Swidan to start with our webinar. Welcome and thank you so much for being with us.
Well, thanks, Ashley, for the introduction. Welcome, everybody. It's nice to have everybody here this evening with us. I know it's probably hot all across the country, so thank you for being with me for the next hour or so instead of being by a pool or a park or somewhere fun. But hopefully we'll keep this one fun, engaging, and interactive. And hopefully also we'll see you either in Colorado next month or in Nashville in September for this module. So what I'd like to do in the next, hour or so is really to kind of show you how we continue to evolve, even with the A4M and our longevity fellowship, and how we continue to kind of connect the dots and really bring in systems biology and systems thinking in longevity medicine, right? A lot of times, it's really, we still continue to evolve. And how do we connect all these dots together? And, Module 3 obviously focuses on brain health, neuropsychiatric type disorders, and things like that. So hopefully we'll have some fun also kind of putting the whole, body together per se. So what are we going to kind of review? Really, what are the limits of single system care, right? We are seeing tougher and tougher patients, sicker and sicker patients. And a lot of times they come from, our colleagues that either were helped some or not helped at all, and they're looking for more answers. And so why now more and more, why isolated, as I call it, organ by organ, treatment or Band-Aid medicine is underperforming, especially in the complex and aging patients that we are seeing. I'm going to review some of the traced assured pathways for this and how do you put this really in a systems biology thinking, whether it's heart disease that you're looking at or brain dysfunction or endocrinology and all that good stuff. So we're going to look at how does oxidative stress, inflammation, and barrier injury, obviously in that link, detoxification challenges, cardiovascular issues, and brain, pathologies. And then how do you apply the systems framework, from intake to innovative testing and some of the multi-system treatment that we will be teaching, obviously, in this module and the many module and amazing educational venues. So I'm sure a lot of you have heard me if you've been in some of the other modules, but if not, obviously I've been with A4M for, totally aging myself, 28 years, but hopefully the longevity medicine tricks and tools that we're learning are working. So, the big thing is, most of medicine still treats organs by organs, right? A lot of time when you go to the cardiologist, a lot of times they're really focused on the hearts and what issues of the heart. But really, these organs, they do not live in separate rooms. I tease that the body didn't get the memo, right? Things that are going on with the brain can affect the heart. Things that are going on with the gut can affect the brain and affect the heart. Liver issues can affect, obviously, what's going on in toxin buildup. So definitely, tonight we're going to look at the wiring and how toxic exposure lights up the liver, the artery walls, and the brain at the same time, right? What's the underlying connecting pathology that sometimes that we're seeing with this multi-system problems that we see in patients? So we're going to kind of look at the interconnected web of longevity, as I call it. So here we know a lot of times, it's really one input, four systems, shared warning. And this is where reductionism, fails here, because really the drivers of aging are shared across multi-systems, and they're not necessarily just hitting one organ at a time, right? So a lot of times, we will see, brain issues, gut issues, vascular issues, liver, and detoxification issues. And a lot of times, the patients will come in with a multi-system problems, right? They're problem list. Sometimes they can have 20, 30 symptoms. And a lot of times, really, it's shared through what is the core, and what is, the biology that's broken, and what's the core cause. So sometimes, the brain, the heart, the gut, they're kind of innocent bystanders, if you will, and they have stuff happening to them. But it could be because huge oxidative stress on the body, inflammatory causing. Obviously, we know chronic low-grade inflammation can really cause a lot of havoc, all over the body, whether, it can contribute to cardiovascular disease, obviously brain issues, neurodegenerative disease in some cases. Obviously, gut, when in doubt, start with the gut and fix the gut, because you really can fix a lot of problems there. The other thing is now, the exposure that everybody has, right? Everybody's swimming in a soup of toxins, as I call it, right? We have obviously things that we touch and are exposed to every day through work, just the air that we breathe, the food that we ingest, and the pesticides, things that we're applying on the skin, right? A lot of people remember the skin is your biggest absorptive surface, right? The average person slaps about 120 chemicals, on their body, and exposed to about 120 chemicals a day. Now we have barrier breaches, right? We used to call it leaky gut syndrome, but you can't say that because then you may not sound as brilliant as you should be. But if you say permeable gut syndrome, right? And now it's kind of accepted finally in mainstream medicine. So this is really where we have, gut breaches, if you will, right? The leaky gut and leaky brain, right? We used to think in the old days, nothing would penetrate the blood-brain barrier, right? That's why it was, tight junctions and things like that. Well, now we know when we have leaky gut, you probably have a leaky brain barrier also. So things that can cross the endothelium and the blood-brain barrier. And, nobody walks in with a healthy gut hardly anymore, right? Everybody's got some degree of dysfunction. And oxidative stress, right? A lot of people are walking in with mitochondriopathies, whether it's due to viruses that they're exposed to, long COVID, and a bunch of, medications that hit mitochondria. So, you'll see high levels of reactive oxygen species, mitochondrial dysfunction, and low-grade inflammation. So all of these, eventually lead to system injury, right? This is when we see vessel dysfunction. So atherosclerosis and cardiovascular disease, neurodegenerative or neuronal type stuff, MS, neuroautoimmune type stuff, autoimmune disease, metabolic damage, insulin resistance. So a lot of times, again, the end organ damage, if you will, or the end, symptom that we see, we've had exposure. Sometimes it's 5, 10, 20 years in the making before you see the end product of system injury. So what are the environmental toxins and the multi-system impact that we're seeing every day nowadays, right? So everybody's exposed to toxins, right? Whether you're breathing it, you're eating it, you're touching it. And the other thing is sometimes we're really overwhelming the detox systems, right? So we have phase 1, phase 2, and phase 3 detox. And we really need to optimize detox, right? It's almost like you have to do low-grade level detox every day now to keep your body even just pseudo clean. It is crazy. This was a 2009 study. The average newborn, and we're talking newborn, has about 400 chemicals in their body. So the average newborn is born with about 400 chemicals. And obviously with life exposures, that number dramatically increases. And this is why also, a lot of the the detoxification strategies that we have are being overwhelmed because of the amount of toxins that are in there. People are also more sedentary, they're not moving as much, they're not sweating some of these toxins as much. So it's very important to optimize, phase 1, phase 2, and phase 3 detox. But a lot of times what people do is they really do detox wrong. So a lot of times, for example, like in the hormones, everybody's like, well, everybody should be on DIM and indole 3 carbinol, right? Because that supports phase 1 detox. However, if phase 2 and phase 3 is clogged, you actually are going to make more reactive intermediaries so we're going to push phase 1 and the toxins out of it, and they go to phase 2 where they get glucuronidated, conjugated, sulfated, methylated, so they become more water-soluble compounds. But if this system is clogged and not supported, actually you'll make worse, toxin intermediaries or hormonal intermediaries that are actually more DNA damaging. And then phase 3 is gut, right? This is bile, gut, elimination and transport, your kidneys. This is why, you really, when you want to do detox, you have to do it backwards, if you will. You have to support phase 3. So you have to make sure the patient is getting at least 35 grams of fiber per day and work them up to slowly or even more. Soluble and insoluble fiber. Resistant starches as a prebiotic. There's a lot of great data looking on resistant starches. So you can either buy some of these supplements or you can take potatoes and put them in the fridge and that becomes a resistant starch, or rice. Obviously, you have to watch the carb load. If people have bile ducts, great, they'll secrete some bile. But if they don't, you need to support them with something called TUDCA, right? Which is kind of, synthetic, bile-like kind of substances that really help with detox. So you got to give them probiotics, prebiotics, make sure that they're pooping. And because toxins and hormones undergo intrahepatic recirculation. So if phase 3 is clogged, they're not eliminating toxins or some of the hormones, and these things can build on them. Then you support phase 2. So phase 3, you get it going. Then you support phase 2, things like glutathione, NAC, vitamin Bs, magnesium, sulforaphane, resveratrol. So a lot of different things can support phase 2 detox. And then if need be, then you use like indole 3 carbinol and DIM, to support phase 1 detox. If you do gut analysis on patients and you see that their beta glucuronidase is high, so bacterial, byproducts, bacterial beta glucuronidase, they deconjugate estrogens and also they deconjugate toxins. So again, if the patient is not pooping and eliminating and phase 3 is not moving well, you're just going to basically freeze the toxin or the hormone for reabsorption through intrahepatic recirculation. And actually the patients get sicker and sicker because they're actually accumulating these toxins that they were going to basically just poop out. So now they become deconjugated. So again, if you do gut analysis and you see the beta glucuronidase levels are high, you can give a patient calcium D-glucarate, which really helps to lower beta glucuronidase levels, and it can help also with phase 3 detox. So, definitely that's why having a healthy gut is critical. We always say when in doubt, start with the gut, because you can fix a lot of issues with the patient when you fix their gut. We know dysbiosis raises beta glucuronidase activity, obviously as related to estrogen, that's the estrobolome. But also it's the detoxabolome per se, right? Because it's not just estrogen that you're going to deconjugate and eliminate, through feces. So you want to support healthy gut again with fiber, calcium D-glucarate if needed, microbiome balance and all the good stuff that you learn obviously with gut rehab, the 4 R's or the 5 R's. We know also that toxins can drive cardiovascular disease. So, many studies have looked, obviously, if they have metals and other toxins, we increase the risk of cardiovascular disease and increase it by literally double the risk of ischemic heart disease. And, especially with smokers, right? So smokers, obviously, we have the vasoconstrictive, the toxins, but, smokers also, cigarette tobacco has a lot of cadmium in it. So you'll also see in patients that smoke, in addition to maybe some other heavy metals that they're getting from food and soil and, other exposures, but cadmium, especially in smokers, tends to be very high in those patients because tobacco has a lot of cadmium in it. The other thing, toxins also, across the barrier, if you will, and into the brain, right? A lot of times now we are learning that kind of, just like you can have a leaky gut, you can have a leaky brain. So things historically that would not get into the brain, right? That was kind of the holy grail and it was always protected, that things are leaking in. You saw the big news, obviously, on microplastics, right? But now we have a lot of particulate matters, these nanoparticles, that are crossing the blood-brain barrier. What do? When this weird stuff gets into the brain that shouldn't, obviously, a lot of the microglia and astrocytes, so these are the soldiers that are protecting the brain, right? So they kind of launch these inflammatory attack, right? Because they want to get them out of there. They think they're bad actors. And so they cause a lot of neuroinflammation. They increase oxidative stress and mitochondrial dysfunction. Also, heavy metals, we know, hit the mitochondria, just like viruses, just like certain bacteria. So sometimes, again, if you have a lot of heavy metals, viruses, toxins, you can see cognitive decline and accelerated brain aging, right? This is very common problem that people now come in, mild cognitive impairment. You're seeing it, so definitely it's in everybody's best interest, obviously, to reduce the exposure, to change the trajectory of all these insults on the various organ system, whether it's the brain, the heart, the liver, the gut, the kidney, and this is why all these are so interconnected, because we have like the gut brain heart axis, right? So we know toxin exposure shifts the microbiome and the balance, heavy metals, drug-induced nutrient depletion, microbiome, drug-induced microbiome imbalance that can also do that. So we know toxic exposure shifts the microbiome, the barrier integrity, and it generates systemic metabolites that can strike all three systems, right? So, sorry, I don't know why my it keeps, I hope it's not affecting your slides. I don't know why it's doing this. So all these systems, the gut, brain, and heart axis, right? So we know when we have dysbiosis, we increase the risk of, we're increasing the risk of, I just want to make sure you guys still see the slides. I'm sorry about this. I don't know. My computer is doing something weird. Let me just make sure. Okay. So we see, obviously, with the dysbiosis, the permeability, right? They generate certain metabolites. We know when, some of these toxins are also hitting the heart, they make the platelets kind of more reactive. They may increase the risk of thrombosis. The brain, we talked about neuroinflammation. But like, for example, you have like TMAO, right? So this is a metabolite. It's a gut microbial metabolite. Trimethylamine and oxide. So you can actually get a blood test and measure this. So we know in patients like that, if they have high levels of TMAO, that's something you definitely want to fix, especially in patients that eat a lot of carnitine, obviously meats, because they have carnitines, CoQ10, things like that. So we know, like, even if you take carnitine supplements and if you have high levels of TMAO, that can really increase potentially long-term the risk of cardiovascular disease. So that is another metabolite that you can check. And so in this 1 study, actually, TMAO independently predicted 3-year heart attack and stroke risk, and because it enhances platelet reactivity too. So again, this is another lever that you can test, see what's going on, and obviously affect by fixing the dysbiosis, fixing the gut, you can again indirectly decrease the risk of, heart disease when you address those. So let's look at a patient case to kind of show you like the systems approach in action. So for example, this is a 54-year-old, he's an executive, he's a founder of a big company. So his chief complains, he comes in, I'm really tired and fatigued, by 3:00, I'm done, brain fog, especially, slowing recall. I used to be, he states, I'm used to be like really sharp, everything. I'm running a massive company and now I'm just exhausted. My brain is not working well. I'm not sleeping well. I feel like I'm aging fast, right? And so a lot of times, so if somebody comes in like that, what do we, sometimes, yes, we'll check like a thyroid, we'll check an anemia panel, just to make sure there's like no blood, low blood, we'll check thyroid just to make sure. And then we usually say, okay, these are good, you're fine. But I think a lot of times the history, because by the time they get to this stage, this is 5, 10, or 20 year in the making of whether it's exposure, toxin buildup, insulin resistance, gut dysbiosis, and finally it's, what kind of breaks the camel's back, and it breaks all these systems. So sometimes, the history that we may, skip or not ask about, right? He's been working for 20 years in this renovated industrial loft and lives in an older home. So there could be obviously mold exposure, right? Water damage, mold exposure, older homes with lead, piping. So that could be leading, obviously, finally to the toxicology and toxins, or mold toxicity. He loves sushi, so he was eating lots of fish, tuna and things like that. Remember, salmon, tuna, and the bigger fish, they have a lot more mercury in them. Conventional produce, he doesn't believe in organic. He always, stored his food in plastics, was eating, heating them in the microwave, bottled water, obviously in the office. As a hobby, he used to work with a lot of solvents and metals, and also to de-stress in the evening. A lot of times he would have 1 or 2 glasses of whiskey and, didn't sleep much because he couldn't, catch up with work. So, conventional workup was quote unquote normal because, the thyroid looked fine, no anemia, they said kind of basically, well, just sleep and whatever. But a lot of times when you really dig deeper to go look at glucose and insulin. So his insulin was also high. Remember, neurodegenerative, dementia or cognitive decline, that's diabetes type 3, right? Very important to control their insulin resistance and fix the sugars. He was basically told to exercise more because his fasting glucose was slightly borderline, exercise more, stress less, and clean up, right? And this is what you hear a lot of that story. So the standard labs are normal, but what else were we measuring in this one, right? So lipid panel, fine. Fasting glucose was borderline. Blood pressure was okay. A1C, he's not diabetic yet. So they said, you're fine, right? Now, a lot of times we always dig deeper, right? So we are getting the expanded lipid profile to see, is there something in there? And it's not just lipids, right? When you have lipid dysregulation, that tells you of an upstream problem, oxidative stress, inflammation. A lot of times you'll see cholesterol levels hugely spike up if somebody's under attack or under a lot of inflammatory burden. And then sometimes that can be corrected, right? So you look at the pattern, you look at ApoB, LP(a). We always check fasting insulin, right? Because a lot of times, the insulin is high for 3 to 5 to 10 years before we see the A1C and the blood glucose spike up. We're going to check a TMAO and HSCRP and look at inflammation. We could do obviously gut profiles on him. We're going to look at toxic metals when somebody tells me that he's been kind of playing with some of the hobby type stuff. He was working with solvents and paints and things like that. Also lives in an older home with lead pipes, smoking and looking at cadmium burden. You can also look at the CBC. You could look at the GGT. If his GGT is low, that's an indirect measure of glutathione. So his GGT was low. So definitely he had glutathione. And remember, glutathione is the universal detoxer, right? You could look at the CBC with diff, like if his mean platelet volume was elevated, that tells you that's really an indirect measure of interleukin 6, and that tells you inflammation also. You could look at the CBC with diff and look at the MAB percent and add them up. And if it's above, 10, that tells you again, he has gut inflammation. So there is so much that we can just glean from slightly having more advanced labs that can really put this whole picture together. So when we just say, oh, your glucose is fine, you don't have anemia, your blood pressure is okay, you're fine. But when we dig deeper, all these systems were dysregulated, right? So it's not that the patients are fine. It's sometimes we're not measuring to really see what else could be going on with them. So the comprehensive, longevity assessment and what we're always teaching you, all these, extra tools that we teach you in the fellowship and in the various educational efforts that we do, we are digging deeper. So for heart, we are going to measure these more advanced lipid profiles. We're going to get the fasting insulin and home IR. We're going to get the HSCRP. We're going to get homocysteine levels because that tells us an indirect measure of methylation. And to see, because that also tells us indirectly if he's a good detoxer or not, or if they have the genetic SNP for the methylation issues. We're going to measure a TMAO because if that's elevated, we really want to work on his gut dysbiosis to decrease the incidence and hopefully the risk of cardiovascular disease. We're going to get an omega-3 index and optimize that, right? It should be at least 8% or greater. He's 54 years old, has had a lot of this heavy metal burden, possibly mold toxin, stress, drinking, and family history of heart disease. We are going to get minimally a CAC score on him or a CTA with clearly to look at kind of calcified plaques and then soft plaques in somebody like him. We're going to look at his detox capacity, right? You can get a challenged heavy metal test to see if it's high. Mycotoxin screen, if indicated. Again, it kind of sounded like he lived in a water damaged, possibly building. The glutathione, like I mentioned to you, GGT is an indirect measure of glutathione reserves. Now, in some patients, we may get genetic testing also, especially if we have high homocysteine levels. And if we give them the activated B vitamins and they're not budging, sometimes we may need to do kind of their genetic SNPs to see which part of the methylation cycles or the other cycles that are broke, with God's blueprint as ITs, and what other ways we need to modulate it. What else are we going to do for the brain in the longevity assessment? How can we protect the brain, obviously, and keep it, get rid of, give him his sharp brain back, right? So he's not, fatigued, obviously physically, but also his brain is not as sharp as it used to be. We're going to look at his inflammatory cascades, CRP will tell us something, interleukin 6, or like I said, mean platelet volume is an indirect measure of that. We'll look at homocysteine because that tells us methylation. You can get ApoE genotyping, right? Obviously, if he's at high risk of neurodegenerative disorders, if he has the ApoE4, obviously, genotype. Now it's great. We can measure, neurofilaments, synuclein levels, p-tau, proteinopathies, right? Now it's a blood test, which is awesome. And we really like to get these as a baseline because you want to look at the trend, right? If the, the neurofilament numbers and the p-taus and alpha-synuclein levels are kind of creeping up, obviously we want to do everything in our power to stop the progression. And obviously, hopefully, especially if it's caught early, kind of dementive type processes, you can reverse them. And then, do cognoscopies, right? Do the MOCA scores, do the mini mentals and things like that. You should be doing this on all your patients just to get, what's their cognitive battery or cognitive, cognoscopies, as I call them. The other thing with gut and barrier testing, right? We're going, we could get microbiome testing, the TMA, like I mentioned, dietary pattern reviews, what's their diets, what are some foods. We can get food intolerance testing. Obviously, if they have food allergies, they'll tell you that, right? Because usually those are more, pronounced. So, and then the other thing, like the microplastics, right? We don't really have good testing for that yet. We can test for glyphosates. We can test for a lot of other toxins. The microplastics now, they're finding, we're finding plastics in the arteries. They're finding it in brain on autopsies and stuff. The average person now, they seem to think we have a teaspoon of plastic floating, in our arteries and in our brain, right? So why do we care? Again, this is just another irritant to the body, and it seems to increase the risks of heart attacks, strokes, and things like that, because it's just another thing that should not be there. So it's very important, like I said, you want to get all these numbers, you want to put them into a dashboard, but it's very important to treat the network and not necessarily just the numbers. Sometimes, right, we're really just focused like, oh my God, their LDL is high. Okay, well, let's give them, everything in the book to get the LDLs, if we leave it up to the cardiologist, they basically want cholesterol's of 0 now and LDLs of 0. But but what else is really triggering that, right? The most important thing is definitely the numbers matter, but also don't forget about the rest of the network, right? You want to reduce the input, right? So if they have mold, you want to remediate the exposures. If they have, lead piping, well, lead paint, lead anything, obviously we have to be careful and clean that up. Filter the water, right? Get a reverse osmosis at least on their drinking water, cooking water, in the showers, right? You can get simple shower head filters now. Because remember, your largest absorptive surface is the skin. Swap plastics for glassware, adjust seafood, right? Eat sardines and smaller fish that tend to have a lot less mercury in microplastics now, right? Fish, we used to worry about mostly mercury, but now, because they're eating all these plastics in the ocean, unfortunately, fish has a lot of microplastics in them. And obviously, I'm a buzzkill. We used to think, well, maybe 1 or 2 glasses of alcohol, but now basically the studies are showing no alcohol, right? You want to support their detox mechanisms, like I mentioned, phase 3 to phase 2 and phase 1, detox, and some of the ones that we mentioned. You definitely want to protect the heart. So you want to target ApoB and LDLs and optimize their omega-3 index, reverse the insulin resistance. And obviously, you don't want to do heavy metal chelation. Obviously, you have to be very trained for that. You have to make sure the body is ready, because you don't want to be pulling all this stuff out, but it has no way to come out properly, right? You always have to fix the gut, support the detox pathways, handle the inflammation, fix the cardiovascular risk factors, and then slowly, chelate the stuff out. You want to look at their, diet, obviously clean it out. If it's the SAD diet, the Mediterranean diet always fares much better in clinical trials. You want to give them microbiome support, pre and pro, biotics, lower TMO, obviously get them to sleep. That's how the brain cleans, right? Itself, like the lymphatic system. So all of those are very important in order not just to focus on getting, omega-3 index to 8 and ApoB, to whatever number we need. All these things have to work in concert in order to really fix all the symptoms that he was complaining of. Because yes, you can get ApoB in the right thing with medications or, probably mostly medications, but that's not going to really fix a lot of the other symptoms he's complaining of. You have to fix the network and not just the single number of issues. So what do you do on Monday morning? So our always approach really when we're teaching in the fellowship is, okay, great. We give you all this amazing education. How do you put it together for a Monday morning approach and putting it into practice, right? So our goal really in kind of the longevity framework, if you will, is to really detect and reverse dysfunction early, right? The way we were most of us trained, it was really Band-Aid medicine, right? We were trained like symptom drug, symptom surgery. With longevity now, our goal is to pick up the insulin dysregulation 10 years before we see the diabetes and really work on fixing the insulin resistance. And what's driving that? Is it inflammation? Is it heavy metal toxicity? Is it overweight? Is it the diet? Is it the stress and cortisol dysregulation? So we always want to detect and reverse dysfunction early. Timing is, again, we want to work in that 10 to 20 year silent window where, people are dysregulated. They're slowly developing the heart disease and they're slowly developing the insulin resistance, but we don't want to wait till they're diagnosed with diabetes or, have a MI or a stroke and things like that. We really want to kind of change our thinking from, normal to optimal, right? So a lot of times we'll see this in traditional medicine, right? For example, vitamin D, if you have a level of 29, it's low, but if the level is 30, it's normal. But really, is that optimal? And then to the body, what is the difference between a vitamin D of 29 and 30, right? Nothing. So we always want like our vitamin D levels, for example, to be really 60 to 80. That would be more optimal, or at least 50 to be optimal. Lipids, LDL, total cholesterol, right? It is a lot of times what was measured. But now, and thank God, finally, really it's mainstream now that we should be more focused in measuring ApoB levels, Lp(a), and looking at the pattern and the particle number, right? We've been teaching that for literally 25 years here in measuring these. Again, fasting insulin that should have been added to the panel, long time ago, but it's not yet. It's not really, every day. And so again, you want to work across the network and see what's really causing all of that. So the testing menu, what can you do and increase now, even as I call it primary medicine 101, if you will, how you can do longevity medicine 101, even in your daily busy practice. Because we know, everybody, you have that 15-minute with the patient and sometimes you have to address a lot of issues. But really to add like ApoB and Lp(a) to their lipid panel, that would be a huge lipid upgrade. To look at Lp(a), remember that's a genetic marker, right? To add fasting insulin now in addition to your A1C and fasting glucose. Check as HSCRP or CRP on patients. Look at their inflammatory burden. Get a homocysteine levels. And I know sometimes insurances will tell you, well, we don't cover that because it didn't fare out in clinical trials and things. But it really can tell you a lot of their detoxification ability and how they're methylating things out. So, GGT, as I mentioned, is a glutathione, omega-3 indexes. Again, most labs have these. Now, if they have, risk of heart disease, I always like a CAC score on men and women, in the 40-year-old club, right? We're seeing heart attacks younger and younger. The TMAO, which a lot of labs have, CGM sometimes, even in non-diabetics, they really give you feedback on what's going on. And now, really the frontier, right? We will teach you about biological age and epigenetic clocks, advanced cardiac imaging if need be, microtoxins and metabolomics. Now we can also get much better brain risk factors, right? So you can get their ApoE genetic profile, p-tau and alpha-synuclein levels, neurofilament levels. This is really exciting where now we can check these in a blood test and see what are the brain risk factors now, where in the old days, we really didn't have much way to test the brain and see what's going on besides when people were really developing dementia, right? So always, with our treatments, so how do you put this like into the treatment ladders, if you will? So like rung one, just like with anything, you can get all this fancy schmancy testing, and absolutely it's very helpful, but people still have to do this. Now hormones are huge, right? We unvilified hormones and everybody wants hormones. So everybody walks in and they want hormones, but you still cannot hormone your way out of a dysregulated cortisol HPA system, a poor diet, no sleep. Hormones are not going to fix everything. And that's what sometimes people like, oh my God, I'm not going to do anything, but I'm going to get hormones. And then they come back to you and go, I don't feel good. I don't feel any different. Well, of course they're not. If they're not sleeping, stressed out of their mind, eating like crap, right? They still have to exercise. They want to get your VO2 max out. They want to do strength training, especially now that, with everybody's on vitamin GLPs, ITs, right? You want to make sure they're doing all the right stuff. Sleeping at least, 7 to 8 hours a day. That's how you clean out your body, your brain, the lymphatic system. We have to control stress. We have to improve nutrition. Rung two, obviously, would be to look at, decreasing the risk factors, right? Whether it's ApoB, their LDL levels, their omega indexes, reversing their insulin resistance, managing metal or mycotoxin burden. Again, very important to decrease the input and the burden of the input. Then we have to give targeted nutraceutical, right? Sometimes we'll have patients walking in with 50, 60 supplements a day. And I was like, well, what is all this for? And I go, well, I read about this. This clinician put me for this, that clinician put me for that. And they come in with 50 supplements, just like now. Sometimes we have polypharmacy, we have polynutraceuticals. So definitely you want to look at the supplements. You want to use some that have multiple mechanisms of action that can address multiple things. For example, like glutathione, the universal detoxer. Well, that's a great one to support detoxification. It's great for brain health. It's great, for detoxing, and it really is helpful. Omega-3, right? Most patients are deficient in omega-3s because our diet, the SAD diet is so hard and is so high in omega-6. So sometimes like giving somebody omega-3, optimizing their vitamin D levels, giving them NAC or glutathione and a B complex, and really improving their diet and fiber can have huge impact on how they feel. And then rung four, right? This is when, hey, they may need GLPs. They may need, definitely, if they're appropriate candidate and they're not making hormones, they may need some of the new cool technologies, rapamycin, NAD, peptides, right? But again, I'll have, sometimes, we'll see patients, like we just had a fellow submit a patient and it was like, they did everything, they're doing exosomes, stem cells, NAD, peptide stacks. They went to Mars and got red dirt and they're not feeling any better. And you know what? I looked at their labs and I said, their urine pH is 5. I don't care what you give them. And now you're doing stem cells. So you're putting this liquid gold in vinegar, which their body was so acidic. I said, do you think any of that is going to help? So clearly they have a mitochondriopathy. Clearly they have cellular and energetic issues. And clearly they're very acidic. I don't care what you give them. You can give them all the GLPs, hormones, peptides that you want. They're not going to feel good because they're all going in vinegar. So sometimes, you really have to do this in these rungs and not just like go to the peptides and stem cells and exosomes and hormones and GLP and these big guns. They absolutely have their role, but you also have to do the foundational stuff still. So this is just, something for you guys to really, you can do this week. So add, a cool new lab like ApoB, LP-little-a, and fasting insulin now to your typical panel that you check. If you have somebody really tired, don't just check a TSH with free T4. Check a T3 and thyroid antibodies and see, do they have an autoimmune Hashimoto's process going on? Is that why they're tired? And because we just checked a TSH, we don't know if they're converting enough of the T4 to the T3, which is the active one. Ask them one new intake question. Ask them, hey, tell me about your home, your water, or your work exposures. What chemicals, what is your work? Do you have any chemical exposures? Do you have shower filters on your shower heads? Do you use a reverse osmosis system? Have you had water damage in your home or your place of work? And do you think there could be mold exposure? Order a CAC, right? Especially if you have somebody with intermediate cardiovascular risk, get a CAC score and see, now they're very inexpensive. And, very important to tell you if they have high CAC score, obviously you want to be much more aggressive, obviously, in their treatment. Write one exercise prescription as ITs, right? Give them VO2 max, zone 2, and strength target, depending on where they're starting, right? I always say, don't freak them out. But if they're just on the couch, just have them, even walk around the house for now. That would be better than nothing, right? And then pick one patient that you're really having hard time getting better to run the full system that we just reviewed on, and to do a little bit of these advanced labs and to start connecting all of these systems or the symptoms that you're seeing together. Now, the brain is really a systems organ. And so a lot of time, brain health, it's gut health, it's detox, it's vascular health, right? If your heart is not well, your brain is not going to be well. If your arteries are clogged in your heart, guess what? They're probably clogged up here too. It's mitochondrial, the energy powerhouses, right? This is really where module 3 goes really deep into all of these systems. We look at gut, we look at dysbiosis, we look at gut testing and lipopolysaccharides, because we know when you have bad gut, you have bad brain, right? Because it activates the microglia and causes neuroinflammation. We know if you have vascular disease, endothelial dysfunction, we probably have blood-brain barrier injury in things that usually wouldn't have gotten into the brain will get into the brain. Mitochondria, it's energy failure, right? A lot of times viruses, bacteria, toxins, they really stop your mitochondria from functioning properly. So looking at mitochondrial health, again, when you see high pH. This is such a simple test that everybody should be doing. You should have litmus paper in your office. You can just do litmus paper test in the office in their saliva or urine. And if they're acidic, guess what? They're not exchanging things well. Their mitochondria is not healthy and energetic. We could look at detox pathways. Like I said, if their homocysteine is high, they're not methylating well. If their GGT is low, they don't have enough glutathione and they're probably not detoxing well. Obviously, look at hormones. Hormones are very important for, brain. Estrogen, especially in women, it grows the brain because it really enhances the effects of brain-derived neurotrophic factors, right? That's the only part that you want to get fatter as you age, is your brain, right? You don't want it shrinking. Usually it shrinks, and you want it to stay nice and plump and keep these neurons growing and grooming. And also immune system, right? We know toll-like receptors in the brain, a lot of the microglia, when it's activated, it's going to lead to neuroinflammation. So things like, interleukin-6, HSCRP, and any kind of, any inflammatory mediators like cedrate and, ANAs and things like that, when they're off, they just tell you there's immune dysregulation that's going on. So the brain workup that you really want to run, if somebody is complaining of cognitive decline, brain fog, it's not sharp as it used to be, they're dementing or they have high rates of dementia in the family, obviously you can do the genetic stuff, right? But look at neuroinflammation. Look at these lab tests. Look at the metabolic stuff. We know glucose insulin resistance is type 3 diabetes in the brain, right? So look at all these metabolic dysfunctions that we can get. Look at the toxic burdens. You can get organic acids. Again, we teach you on how to get those, how to read them. Neurotransmitter testing. We can, show you how to do that and read that. Obviously, hormonal testing. Hormones are very important, like I mentioned, for the brain, the body, the heart, the bone. Look at the p-taus, the ApoB neurofilament testing. Will also show you some really cool imaging technologies in Module 3 and how you can assess the brain and how well it's functioning. Functional type labs, we'll go through, I call them neurometrics, right? We're going to go through a lot of the tools. How do you measure functionally how well the brain is performing? QEEGs and, some other things, Brain Master, cognitive battery, some of the cool imaging and looking at neurofibrillatory tangles. We'll go through all that in Module 3. Look at heart rate variability, right? The heart and the brain, they're constantly communicating, and HRV numbers, the lower they are, that also tells you the body's under a lot of stress, looking at gut testing, because again, when you have bad gut, you have bad brain. So, how do you treat that? Again, it's really similar, right? When you help one system, so you want to reduce the load, restore the substrate. So you want to remove metals, mold, and infections. You want to lower glucose and insulin, whether it's exercise, better diet, sleeping better, or, GLP-1s, right? Why do we think GLPs are protecting the brain now, right? They're like good for everything because they're anti-inflammatory. When you reduce insulin resistance, you reduce inflammation, and you help every system. B vitamins and activated Bs can lower homocysteines. Omega-3s fix omega-3 index. It's anti-inflammatory. Magnesium, critical. 80% of the population is low in magnesium, but very critical for shutting the NMDA receptors in the brain, which also propagate neuroinflammation. So magnesium is extremely critical for the brain. Glutathione and sulforaphane, again, very protective to restore the substrates and support the detox in brain. Exercise, we know it increases brain-derived neurotrophic factors, and it helps with training, resistance and, running, things like that, Mediterranean diets, sleep, extremely important. And now there's a lot of really cool stuff, right? Regenerative type stuff, exosomes, stem cell, peptides, NAD, photobiomodulation, HBOT, there's a lot of really cool stuff. We always will teach you how to fix the gut, because when you fix the gut, you fix a lot of the issues in the brain. We review how to address drainage detox in the sleeping brain. Remember, sleep is the brain's wash cycle, as I call it. So protect deep sleep. It's basically the detoxification intervention, especially critical in ApoE4, genotype. We'll cover some IV nutrients and chelation in selected casing and who is a candidate for that. You want patients to sweat, exercise and sweat, or go into saunas. But again, you want to support the brain. You want to give them binders. You want to give them glutathione before they go and sweat out all these toxins. So again, you got to do this in a systematic, approach. The regenerative, tier, if you will, hormones, as we mentioned, again, all of them very important. The sex hormone optimization and thyroid optimization. Mitochondria. What supports your mitochondria? D-ribose. I love 5 grams of D-ribose twice a day in somebody's water. It's giving their mitochondria energy as they go through the day. Creatine, right? There's tons of data now on creatine. If it's one supplement, that you should add, unless you have obviously kidney disease, is creatine. It's great for obviously muscle type stuff, but for the neurocognitive, optimization now in the studies that we're seeing on that, look for drug-induced nutrient depletion of CoQ10. So your metformins and OCPs and blood pressure meds and diabetes meds, a lot of them cause CoQ10 deficiency. So make sure you can measure that level and optimize. Peptides, there's definitely, there's still experimental, some data it's popping on cerebrolysin, BPC 157, dihexa, CMAX, and Selenac, that we'll cover a little bit. And now the devices that I mentioned a little bit earlier. So here in some of the slides, I put really some of the supplements that I recommend and also some of the doses that have been studied. Now, magnesium, you guys know there's a lot of different salts, right? Magnesium glycinate is the one that's best absorbed. But for brain stuff, magnesium threonate actually gets into the brain the best. And so Mactine is the branded magnesium salt for that. Creatine, as we mentioned, CoQ10, 200 to 300 milligrams, especially if they're on drugs that deplete CoQ10. Some of the peptides, obviously there's a lot of interest in peptides right now. We're waiting for the FDA decision later this month on if some of the peptides will be added again to the category that's okay to compound for compounding pharmacies. But you see, there's a lot of interest for the brains, more helpful ones. Cerebrolysin, there's some data on it, BPC 157, some experimental and animal data, CMAX and Selenac, those are intranasal. Again, very limited studies, dihexa, KPV. So it's really interesting. There's a lot of interest in peptides and more studies. So stay tuned for that, and we'll always keep you updated as kind of the science morphs. Just kind of a couple minutes on the female brain, hormones and reversing decline. Lisa Mosconi did a lot of this because remember, dementia runs much more commonly in women as compared to men. And so what we see is, estrogen is a master regulator of neuronal glucose metabolism. So as it falls in the menopausal transition, the estrogen network basically uncouples, and the brain uses big power source, if you will, the bioenergetic system. And that's why we see Alzheimer's, dementia, and other dementive disorders much more commonly in women than in men. So, brain glucose metabolism, we see decrease in hippocampal volume, and we see increase in amyloid beta deposition. So it's not just all obviously estrogen, but definitely hormones is one major, part of that, and why we have to look at it. Because in menopause, we definitely see these decreases in energy, decrease in hippocampal volume, which is obviously the hippocampus critical for memory, and then amyloid deposition. So the brain is always screaming for estrogen. When you lose it, brain estrogen receptor density rises. Higher estrogen receptor density obviously tracks with poorer memory and more symptoms. I knew exactly when the estrogen dropped in my mom because I tease of like the brain and the mouth were not connecting, anymore, right? More memory, word finding difficulty, and things like that you kind of start noticing in women. So what does the data show on hormone therapy in the brain, right? It's a bit conflicting, but basically the bottom line is the earlier, the better. So, there's this timing hypothesis with hormones, as we all know, for brain protection, bone protection, heart protection, and all the good benefits of that is the earlier that we start them, the better. So in the KEEPS cognitive trial arm, they said they showed no cognitive harm, because some studies said, hormones are bad, and they're causing cognitive decline, but actually no cognitive benefit when started later. And so most of the potential detrimental effect of hormones on cognition seems to be if it started too late. And that's why the earlier we start, the better. Transdermal is safer. Obviously, we know because of less clotting risk. And, like I said, the earlier, the better. And this is, this is interesting. Cognition can bend, right? Dr. Dale Bredesen published a lot on this. So 20 weeks of intensive multi-dome lifestyle improved, cognition and function in mild cognitive decline. This was the Ornish trial, multi-diet, exercise, cognitive training, vascular care, and so on. So, the bottom line is we can bend it and reverse it, especially if it's caught early. So very interesting. A lot of really cool stuff happening in the exosome stem cell with some laser therapies, in some parts across the world, for dementive neurodegenerative disorders. And some of the emerging supplements, right? Lion's mane mushroom, more and more data, we're finding on that. SPMs, they're anti-inflammatory. Low dose naltrexone, remember, it's really the best thing that we have for neuroinflammation. Elevated now, like I said, we can check these p-taus, neurofilaments, and GFAP in the blood now, right? So it's really nice. What do? It's anti-inflammation, anti-inflammation, anti-inflammation. So very important. So, just a good CBC with DIF can tell you so much. Look at their hemoglobin, hematocrit, MCV, right? MCV high, they need B12 and folate. And don't wait till it's really high. If they're trekking higher and they've been trending upwards, guess what? Probably they're not absorbing B12 and folate, as well. MCV low, their iron, and really you need a ferritin level of 50 at least for a lot of things to work well. Again, if the RDW is high, a lot of times we're not taught how to read those, right? If the RDW is high, that tells you oxidative stress. WBCs, right? Look at neutrophils to lymphocyte ratios, high neutrophils, stress and infection, low lymphocytes, immune aging, and look at the neutrophil to lymphocyte ratio, very important. Also look at the monocytes, eosinophils, and basos, like that's what I was referring to. If the MEB is above 10% when you add them up, the percentages, that tells you gut inflammation. Platelets, again, if they have high platelets, reactive inflammation, low could be marrow problems or consumption, and high MVP is platelet activation and inflammation. So, look at these optimal numbers, and, there's a lot that you can tell from these labs, right? So dementia prevention, a lot of times if we catch it early, we can, dementia is preventable by addressing these 14 modifiable risk factors, right? Hearing loss, we know hearing loss is associated with more dementia. LDL in dysregulated lipids, depression, head injury, physical inactivities, diabetes, smoking, hypertension, obesity, and excessive alcohol, social isolation, air pollution, vision loss. So, keep optimizing these so you can obviously decrease the rate of dementia. So in module 3, this is just to kind of give you a flavor of what we will be covering. There's so much more, we'll be talking about, detoxification in much more depth, the cardiovascular optimization, brain and cognitive protocols, neuropsychiatric disorders, and what do they mean? We'll be talking about psychedelics, marijuana, LDN, oxytocin. I'll be covering that. We'll be talking about the gut and brain connection, hormones and peptides, and, some additional labs, and imaging technologies, neurometrics, and how do you measure how well the brain is functioning. So, and as Ashley said, they're running this promo, save $100 with this code. And for those of you that know me, usually you know how to find with me, but you can scan this QR code, or my email is here if you have any questions. So thank you for your attention. Sorry, I went a couple over, and let me see if we have questions. I'm happy to answer any questions that you may have. Okay, Victor says, just very appreciative of this webinar. Have not listened to this in such a long time. It's awesome. Okay, well, glad, Victor. I'm glad you enjoyed it. I love the brain, as you guys can tell. Okay, they want me to pull out the QR code. Hold on one second, please. Let me pull that up again for everybody. There you go. I think you can see it now. Okay. And can you discuss how you use the CBC to determine GI dysfunction? Yeah, I can't remember in which one. I did like literally 20 minutes on how to read a CBC. But just to kind of give you the poor man's test for gut inflammation, if you get a CBC with diff, and if you look at the monocytes, eosinophils and basophils, and if you add the percentages, so, if you add monos, eosinophils, and basos, MEB, and if the percent total is above 7, that tells you, hey, the gut is a little bit inflamed. Above 10, it's really ticked off. And as the number goes up, the gut is more inflamed. And why is that? Because 80% of your immune system lines the GI tract, right? So when you see a lot of inflammation in the monocytes, eosinophils, and basos, that tells you that the gut is on fire. Now, if the number, relatively speaking, let's say, for example, eosinophils is higher than monos, that usually tells you that's more of an allergic type reaction, right? Because eosinophils, histamine, more allergic-y type reactions. Basos, sometimes we can see that with parasites and certain, parasitic infections. Monos, obviously, it's kind of like the white blood soldiers, that usually tells you like, hey, something is tricking. And also if you get like IgA, like on gut testing, if you see their IgA levels is more elevated, because remember, secretory IgA is what lines the GI tract. And, that's your first line of defense in the immune system. So if you see high IgA, something that's coming in is really ticking off the drugs. They're ticking off the body per se. Okay. Could you please help us better understand the order of operation in these kind of cases? What therapies and changes you ensure they do first and last as to mitigate symptoms and to maximize how much resolution? Yeah, no, Great question. As far as, would you start all these supplements and all these things all at once? No, because if somebody's not even getting off the couch and just eating all white foods all day long and not sleeping, clearly, this is why I gave you the rung of the ladder. And that's what I would suggest that you start, work on their diet, work slowly on their sleep, work on their stress reduction, and maybe add 1 or 2 supplements that may give you the most bang for your buck. For example, if they're on a lot of drugs that decrease CoQ10 level, because remember, that's mitochondrial energy, that's energy, and that will give them a little bit of a jolt, if you will, so they can move. So in somebody like that, I would give them CoQ10, glutathione to kind of support the system, especially if they come in with a lot of drugs, and optimize their vitamin D, and that's it. And then work on the other things. And then slowly you can build up as needed for those patients. What do you consider low GGT and high homocysteine? So, that really depends on your labs. I never get a specific number, but, if they're on the low end of your lab, because the ranges could be different, for if you go to Quest versus your hospital labs versus LabCorp, they're slightly different. But if it's low GGT, or on the lower end, that means they probably could use NAC or glutathione support. As far as high homocysteine, optimally, we like a homocysteine level of between 6 and 8. So usually anything, like if it's 9, we wouldn't call that high, but optimally you want it between 6 and 8. Now, you don't want to over methylate people because sometimes that can increase the risk of certain cancers too. So you don't want to under or overdo it. And there was a couple questions on GGT and glutathione. What's the best way? So you can use NAC because it's a lot more cost effective. You can use 500 to 600 milligrams BID. Make sure they're drinking enough water so they don't get kidney stones. But I like NAC just because it tends to be inexpensive and it works really well. It's the precursor to glutathione, right? But the best way to give, because glutathione is not very stable, right? You want to really get a liposomal formulation or a LPT tab, you want the stable forms of glutathione. So I like the liposomal ones because they tend to be more stable and much more effective. Brittany says, I struggle to find a lot of peptides discussed in these lectures. Any recommendations on safe sources? Yeah, Brittany, we offer actually a certification in peptides. So, I mentioned a few here that are more brain targeted, but we literally do tons on peptides and what the science is and the dosing for them, the pros, the cons, what do you have to watch over for, the regulatory landscape. So if you are not with us or if you're new to A4M, definitely speak to your, educational advisor. But we have a certification on peptides. And I think hopefully if we get good news soon in July, there'll be a lot more information. Tell me more about IV micronutrients apart from NAD. Yeah, there's a lot of, we talk in our IV nutrient course, we cover a lot of that. We covered not just NAD, but we cover glutathione, Meyer cocktails, vitamin C, and a bunch of other things. So in our, we have a whole course on IV therapies, some of the peptides, IV therapies and stuff like that we cover in that. But absolutely, there's a lot of IV therapies that you can do, not just obviously NAD, Jason. So, and we cover some in the various, modules based on that. So, okay, I think we got all the questions. So a lot of great questions. So thank you for your attention. Again, I hope this was helpful. We hope to see you with us either next month in Colorado or in September in Nashville. So Ashley and Tiffany, thank you as always, and have a great evening, everybody.
Thank you, Dr. Swidan. Thank you, everyone, for attending. Have a great night.